Esteemed viewer. It is such an interesting evening, especially the fact that the minister told us we should keep smiling while the visitors are around so that they can appreciate our hospitality as Uganda. And I'm glad I'm one of those smiling. But I welcome you to this particular show. This is Family Hour, empowering families one episode at a time. Today is a Tuesday, and every Tuesday we look at health. Today we are looking at another aspect of health, which has a lot of misconceptions, and I believe by the time we end this discussion, most of your questions will be answered. Today we are looking at the burden of sickle cells in Uganda. When we talk about sickle cells, people have their own interpretation of sickle cells. I actually found someone who attributed it to witchcraft, which was really very, very bad. And one time I visited Chirudu Hospital in that ward, and I interacted with the patients, and they told me that the pain they go through cannot be explained. It is too much pain. Now when this child is going through this pain and you keep them in the name of taking them for traditional healing because someone has bewitched your child, then it is really too unfortunate. That is why we cannot just keep quiet about it. About 7.74 million people globally have sickle cells, and as Church of Uganda Family TV, especially on family health, we cannot keep quiet about this as people continue feeding you with a lot of wrong information about sickle cells. That is why with us is none other than Ssekawu Barnabas, who is a clinical officer but also a sickle cell activist. He's going to give us everything we need to know about sickle cells. I believe it will be time that will cut us off, but he's well equipped and he has all the information we need. You're most welcome, sir.
Thank you, sir.
It's such a good evening to all of us, especially having you in studio this evening.
It's a pleasure for me to be here.
Wow. Thank you so much, and kindly greet our viewers, then we get into our discussion today.
Our dear viewers, I bring you warm greetings from Namugongo and the entire sickle cell community of Uganda. I'm really too much humbled to be here and to share a little that I know, such that we can educate and make our communities aware of this phenomenon that is taking people's lives. To begin with, I have to first thank Family TV for having aired up this show. These are one of the initiatives that we always call in for, such that we can sensitize masses. What is sickle cell?
Exactly. Very, very important. What is sickle cell?
Many people, as you've said, there are a lot of misconceptions.
Yes.
There are a lot of misinformation in communities, but what is sickle cell? To begin with, sickle cell is a genetic hemoglobin disorder. Genetic hemoglobin disorder where red blood cells that are responsible to carry oxygen within the body change shape from a normal smooth donut to a half moon or a sickle. You see, red blood cells, naturally they have to be oval. That's in a donut shape. But in sickle cell, they change shape and become sickle, half moon. What causes this?
Yeah, that would be the question, because now when we look at the moon we are referring to, we have a full moon, and then when it is fading, it is half moon. So someone would say, does it mean that my cells are depleting?
Not really. What causes a normal donut shape of a red blood cell to be a half moon or a sickle?
Yes.
This is genetics. Where there is substitution. You see, to go back a little bit, an hemoglobin molecule has components that make it up. It has alpha and beta chains also inside it. But during sickle cell, or when someone has sickle cell, at 60th position of the beta chain, there is substitution of one amino acid, and it is replaced by another amino acid. This is valine being replacing glutamic acid. So this replacement, the substitution of valine for glutamic acid, changes everything in this hemoglobin molecule. So this changes the shape. Later on, when the shape changes from a normal donut to a half moon, which is a sickle, this sickle cell always crystallizes in conditions of low oxygen tensions, and this is where signs and symptoms of sickle cell arise from.
Oh, actually, as we get to the signs and symptoms, when you talked about half moon, I now try to relate the name sickle and then this sickle that is commonly used in villages, which is, does it derive its name from that tool?
Sure.
That tool?
Sure. The appearance of that sickle material, that sickle tool, is actually the very appearance of a sickle cell. Yes, so it derives the name from there.
Okay. Yeah. Well, we look at the signs and symptoms. Probably those early signs that someone can look at. Probably the visible signs.
You see, before I tackle the signs, we need to realistically know why does a donut goes to sickle. We've said there is genetics there. Yes. But this thing started, you see, we shall see the prevalence as you highlighted the statistics. The issue of sickle cell is much in Africa. Long time ago, we believe that we had tropical areas, and actually now Africa is a tropical zonal area. What happened? A lot of mosquitoes were in place. So to evolve and to get a response to malaria, sickles had to come in. What do I mean? Sickle cell trait and sickle cell disease is an evolutionary response.
Actually, now you're making these things a little more complex. We want to understand now the sickle cell disease and the sickle cell trait. What is the difference between the two before we can even get to the evolution?
Sure. Sickle cell disease, you see, sickle cell trait is the possibility of some, because as I told you, hemoglobin, there is hemoglobin A, which is normal, and there is hemoglobin S, which is the sickle. So if someone is having hemoglobin A and hemoglobin S, that is a carrier, that is a trait. So it has to just appear hemoglobin S and hemoglobin S to be called a sickle cell disease. But a trait is hemoglobin 1 and A1, which is known as a carrier phenotypically.
Exactly, that's what I was going to say. That is the trait the same as carrier in our normal language?
Very.
Okay. Now we're on the same page. We continue with the evolution. As
I've told you, we saw in Africa, we had a lot of tropics. Malaria was killing people. So as an evolution to combat the malaria, hemoglobins had to change their shape. So in changing their shape, they developed a sickle shape. That is the genesis of these things. And actually, our people need to know such that we take away the misconceptions. So that is the evolution. And that's why you see areas with a lot of malaria cases. They are the very same areas with a lot of sickle cell cases.
So does it mean that up to now, for instance, I can begin a generation genetically of sickle cell? I mean, if I live in a place that has a lot of mosquitoes, does this mean that at one time I can become a carrier, even when in our family history it doesn't exist?
Yes, true.
Okay.
As a response to of hemoglobin to combat the faraspalum, which has the causative agent of malaria, this hemoglobin changed shape. So with the time, that was the evolutionary response to malaria. Later on, we had sickle.
What is the prevalence of sickle cells in Uganda?
In Uganda here today, you see about 15,000 to 20,000 babies are born with the sickle cell. And the problem is 80% of these babies actually don't celebrate their 50th birthday. That is not good news. That is a problem. So as of today...
50th as month or 50th as year?
50th as of year.
Okay.
Yeah. So the prevalence of sickle cell disease and the prevalence of sickle cell trait, as of now, sickle cell trait is at 13.3%. It means that in every 7 people, there is one with a trait. A trait meaning that I'm having a trait, you my partner, you're having a trait. If we merge, we become a couple, we produce, we are having a risk of 25% to have a sickler. So a prevalence as of now for a trait is 13.3%. It means that 1 in 7, there is a risk. 1 in 7 people has that trait. But for a disease is 0.78, which means that in percent, which means that in around 125 people, there is one with sickle cell. This is a burden. Because again, Uganda is ranked as the 6th country in sub-Saharan Africa with this phenomenon.
We are too close.
Yes, we're too close. And this is not good news. Yeah. So as of now, that's the prevalence with mid-northern Uganda, with higher cases. We're having eastern Uganda and also the central region here. About 2 districts in Uganda, they're having these cases. So on prevalence, that's where we are.
Okay.
Yeah.
Well, you talked about as we were talking about, there's something you talked about, and I think it is important that we talk about it. You said that very many children don't live to see their 50th birthday. I look at a parent who has given birth to their child. Are there any early signs they can look out for as this child is still a baby, a toddler? Are there signs they can look out for before we look at the signs that may show up as someone grows? We look at the baby. Are there signs that a parent can look out for, and then they can at least sense something with their child?
Yes, there are. You see, sickle cell disease always manifests within the first 3 to 6 months, because below 3 months, hemoglobin fetal, there is another type of hemoglobin which it always surpasses the sickle hemoglobin. So the earliest signs of sickle cell include pain, and severe pain that you cannot even imagine. That is one.
How can a parent really tell that my child is now going through pain?
Sure, children don't talk, but they cry. That is an expression of pain. There is an outcry. There is excessive crying all the time. It means that there is a problem somewhere, somehow. 2, acute and chronic infections. You treat your kid becomes sick every day, and then you wonder what is happening. These are the very earliest signs. 3, there is what we call hand-foot syndrome, where feet and the joints of the feet and the joints of the hands swell. You see your child always having swollen feet and hands. 4, there is anemia. You see your kid always pale. You see your kid always not growing well, because also there is delayed growth. You see, so these are the earliest signs of sickle cell disease. So most prominent, anemia, infections, recurrent infections.
Meaning when a parent realizes that a child is not following the normal development pattern, then they should visit a health facility.
Very, 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 to ascertain what is causing this.
How is this diagnosed in the hospital?
Yes, sickle cell. 1, we're having screening tests of sickle cell. It is called this sickling test. And actually, this is the test that we always tell people to go for before they get into marriages. The screening test. At least that one tells us that this is a carrier, this is known. You enter into a marriage, with a predetermined mind. You make real judgment based on correct information. That is one.
Not anticipations.
No, not anticipations. You make informed decisions. That is the sickling. Two, there is the test we call electrophoresis. This test is the confirmatory test that, okay, we are having a percentage of sickle hemoglobin and a percentage of normal hemoglobin. At least this one tells us that in your blood, red blood cells, there is hemoglobin, a percentage which is sickle, like this, a percentage that is normal, like this. So there are ranges that a normal person has to have for those different types of hemoglobin. So those are the two very tests that you always go for, but also there is these other ones that at least can give a general picture, like a complete blood count, that can tell you that, oh look, there is anemia. Why are you anemia? Which you cannot explain for. Look, there are a lot of bacterial infections. White blood cells have gone low or high, yet you don't have an evidence of an infection. So those are some of the tests people can go for to ascertain whether a kid or me or you is having a trait, is Eddie the carrier or a sickler in that case.
Well, we looked at the signs, the early signs and symptoms in babies, in toddlers. We now want to elevate to adulthood. And because, like I said in the introduction, that one time I visited Kirudu and I went to a ward where a few people were admitted. In the first place, I was disheartened by the condition. Why? None of these people had an attendant. So I was like, does it mean that people bring these children and leave them in hospital and go? And then they told me, actually, it's not what you think. When you feel the pain, you don't wait to inform anyone. You just go straight to the hospital. You just inform them that I'm in hospital. That is why most of us don't have attendants. But they bring for us food and then go back and do their normal errands because they are used. So for how long shall someone be in hospital? You can be here for a week and then after a week you're back. So they say, we are used to this situation. And I realized this is really something terrible. But then, even as we talk about this, we have very many parents who still think this is witchcraft, or this is a misfortune, or I annoyed God somehow and so God is punishing me. Let us look at the signs that are surface in an adult, and probably some parent who has not taken their child for a checkup yet can have some heads up.
You see, signs and symptoms, actually some of them and many of them don't go in ages. They don't take years. That, okay, it is because this one is less than this age, he or she will have this. There are some specific ones, like the unfit syndrome, that goes for toddlers, these very little kids. But many of the signs always progress. They just come as mild signs at the beginning. Later on, they can end into crisis or crises. A crisis is a group of a chronic sign or symptom, and also complications. So back to the question, what are other signs of sickle cell disease? One, we have chronic anemia. As earlier said, this anemia is at times is hemolytic. What is hemolytic anemia? Is this anemia caused by rampant breakdown of red blood cells. Remember, these red blood cells are not actually normal in blood. And a normal lifespan of a normal red blood cell is about 3 months. These red blood cells are destroyed by the spleen. But remember, in a sickler, they are not normal, right? So if they are not normal, they are always being broken down earlier than 3 months. They are lifespan of 3 months. So always our sicklers, our people always that suffer chronic anemia. That's why you always advocate for blood donation. Always, because many people die. They need it. Two, we have what we call acute chest syndromes. These are infections of the chest caused by various infections, as I earlier said. We also have complications of stroke. We also have complications of kidney failure. We also have ophthalmological complications. You see, we also have complications of fractures. Because remember, at times of lack of anemia, lack of blood, these bones become vascular. They don't get blood. What happens? They become stiff. Look, so we have a lot of symptoms that arise due to this phenomenon. Yeah.
Well, we are taking a short commercial break. When we return, we are going to continue with this talk, and I believe the message is really coming out very, very clear to you watching us right now. And what we request of you is to stick with us as we come back after the break.
This is Church of Uganda Family TV, enriching lives.
Welcome back from the commercial break. This is Family Hour on Church of Uganda Family TV. We don't take you for granted. We are grateful that you have decided to watch us right now, and we really appreciate your time. That is why we want to use this time you've given us very, very effectively, so that at the end you really have a lot to learn. Now we are looking at the burden of sickle cell, and when we talk about sickle cell, there is really a lot that you and I need to know. That is why we have the one Ssekawu Barnabas, who is a clinical officer but also a sickle cell activist, and I believe he's the right person to share this, because at least he has a lot to share with us, and we really have a lot to learn. Now, talking about the perceptions and the misconceptions, you know, we are Africans, and there is a statement commonly used in Ndwadde z'Abazungu. We attribute them to the whites, and we say, these actually, some people still say, how comes our great-great-grandparents never suffered from such? But probably it could be because of knowledge deficiency. But then there are also other issues we can talk about. Let us talk about some of the misconceptions and the false perceptions that people have over sickle cell disease and sickle cell trait.
Sure. You see, our communities and many people, they have, as you've said, they have misconceptions and perceptions about this phenomenon. One, many think that it's a spiritual disease. Many think that it's a curse due to adultery. Many think that sickle cell, if a person has sickle cell, he or she cannot live beyond 20 years. And this has led many not to get care. You find a parent, you find a person not caring about a sickler,
Yes.
just because she thinks that this person might not live long. Many think that when a woman who is a sickler cannot get married, or a man who is a sickler cannot get a woman. All these misperceptions and misconceptions need to be addressed thoroughly, such that our people can really get real information and collect information.
And I also think that partly it is because of the stigma that we as individuals create for our own selves. For instance, like you said, that a parent has a child who is a sickler, and they just choose to isolate them because they don't see their tomorrow.
You see,
we had sometime back around 2021, we hosted one person here who shared a story and told us, on my 20th birthday, I cried and wept because I knew that was my last day. So he said, I covered myself and I couldn't believe it was me who woke up the following day, because they had told him, you will not go beyond 20 years. And you know, this misconception, probably the isolation and the stigma.
And actually these myths have led to psychological disorders into these communities a lot. And these myths again have made parents to hide. There are children suffering from this phenomenon. Look, yes, there is a lot of stigma and marginalization in communities. You find a family that has a sickler, another family that doesn't, this family that doesn't want to associate, doesn't want the kids of theirs to associate with the kids of these people. Look, where are we taking this nation? These are people, and you see, we need
who didn't choose. Yes.
This is a genetical, as I earlier communicated. This is something genetical, and yes, it's incurable, but techniques are there which later on we shall discuss. The treatment modalities that see out these people to get health well-being.
Well, talking about the stigma you've just talked about, let us talk about the problems associated with specifically the sicklers. What are some of the problems they face?
One, stigma and marginalization. This has led many to have psychological problems like depression, stress and anxiety. Two, and actually anxiety, there is one disorder we call, under anxiety. There is what we call post-stress traumatic disorder. You see this pain, the severe burning pain. I can tell you these people face a lot of pain that even you cannot imagine. So whenever they think of pain, they undergo a psychological problem. That is what we call the PSTD. But other problems, other issues, these our people face who are suffering from sickle cell. Yes, stigma and marginalization. They also drop out of school. Look, because they are always sick. The work productivity, they always not at school. Even the academic performances. Look, they also, because they're always at home. There are this issue of gender-based violence. Some of them are raped. Some of them are defiled. Look, and actually, you see, this problem, as the problem of sickle cell in general, has led to increase the number of single mother parenting. Men run away, and actually we need to tell them, don't run away. Men run away and they leave families. Let alone there are mothers, and these mothers are suffering. You see? So there are a lot, and all this can be addressed if, yes, we say there is a problem and we tackle it all together holistically. Those are some of the problems these people face. And it is really so emotional, especially when you listen to such stories. Like I'll still refer to the experiences these people shared with me, and one of them was
the expensive medicine. I'm forgetting the name.
Hydroxyurea.
Hydroxyl. Yeah,
Yes.
they told me it is really very expensive, and sometimes it's not readily available. But this is the only thing that can support us and keep us alive. And then they also told me about the oxygen and the blood. And I realized we really need to encourage people to donate blood, because much as you think you may never need this blood, but the fact that you have excess in your body, there is someone somewhere who really needs this blood.
Sure.
Okay.
And also to add a little on the issue of hydroxyurea, because that is a very crucial point.
Yes.
We, us who are in activism for a good life, for our sickle cell communities in Uganda, that is a major problem. You see, hydroxyurea is a vital drug these people need. They don't, yes, there is that is dispensed at a free charge in government hospitals that have these clinics, but they don't get it in its adequacy. You see, if someone starts hydroxyurea, he or she has to take a minimum of 1. Look, and few numbers that take actually 1 tablet. Many of them take 2. And 1 tablet of hydroxyurea is between 1,000 to 1,500 Ugandan shillings. Look, a family is already financially dilapidated.
Yes, and drained.
Look, in this economy of food to mouth, a sickler family even cannot afford to get a Panadol to take the temperatures or to take the pain of a sickler. Now this tablet, which is too crucial, is at this cost. So take a family of 3 sicklers, each one taking about 2 tablets a day. Look, so here we ask the ministry to look at avenues of the government through the ministry and parliament, to look in avenues of price minimization and control of this drug. We need a policy. This is a policy matter.
Okay, we shall get into the policy matter, and you tell us what the components of this policy would be. But before we even request the ministry, are there any things that the ministry has really done to create a stabilization in this disease? Yes,
very, and we appreciate, we are proud all the efforts that the Ministry of Health has injected to see that we take this phenomenon away out of Uganda. There are many. Around 2 years, 3 years ago, the ministry initiated and implemented the policy of pneumococcal vaccination to all sicklers of above 2 years. This was a major achievement.
What is it for?
What is it for? As I told you earlier, that our sicklers always have issues with infections.
Yes.
So this pneumococcal vaccine gives them immunity against these infections. So that was one of the greatest breakthroughs that we had via the ministry.
Is it readily available in facilities?
It's readily available.
At a free cost?
Or? At a very free, it's free of charge.
Okay.
Yeah, so it has also continued with the efforts of awareness. It has published many documents about this. You see, last 1 year, the minister, Honorable Dr. Jane Luther Cheng, launched an association that is going to move away this phenomenon. They have also drafted the national plan of sickle cell disease. These are all efforts aimed at streamlining the modes of treatment and patient care, but also to re-energize and increase public awareness about the disease.
Okay.
But there is, they have done a lot, but there is a lot missing.
There is a lot missing.
Yeah.
We look at, we are looking at a lot missing.
Yeah.
As we talk about the ministry and what they have done, I look at oxygen, and during COVID-19 lockdown, I think we had the biggest threat, especially with sicklers, because there was an oxygen deficiency where everyone was at risk of dying because of oxygen. But then I look at these people who need oxygen, especially when they get a severe attack. But when they go to facilities like Mulago, Chirudu, and other government facilities that have these clinics, are they given that prompt attention? Like, is there any emergency attention given to them as they go to these facilities?
Yes, true. You see, as we all, yes, there is emergency treatment, but as you all know, that one of the challenges we have in our health sector is a logistical issue.
Yes.
Logistical problem. There are inadequacy logistics. That is a general problem. So some get emergency care, others don't get emergency care. But that's why you always hear to advocate for more funding. Yes, to advocate for more funding of such initiatives aimed to end these catastrophes. Yes.
Well, you say there is a lot that has not yet been done. What is that a lot? And probably we shall land into the policy that you talked about earlier.
You see, one, as earlier said, hydroxyurea is potent, very crucial, but it's at a high cost. As it is always done to ARVs, that are always available readily and in excess. Why not hydroxyurea also? Because HIV is not genetical, but hydroxyurea is genetical.
And when you look at the statistics, you also realize that at least ARV is equally expensive. But
they are always readily at a free cost in government facilities. Let also hydroxyurea be. Because we're fighting a genetical problem. Right? Not a behavioral problem. So let also hydroxyurea be at a free what? That is our advocation. And that is our activism. If not made free of charge in every health facility where these people go to attain services, let the ministry mandate a control on its price. Yes, we've seen government in price registration of some commodities placing a price maximum and a price minimum of a commodity.
Yes.
That is either high or low to the equilibrium price in market. Let also have a price legislation.
Among the pharmacies that we have, the pharmaceutical companies that we have around within Uganda, do you have any producing this drug? Or it is just
in Uganda, it's just imported.
Okay.
As I know. So it is just imported, but still,
there
can be negotiations here and there, technical,
at least a minimum price.
A minimum price such that our people can access.
Yes,
that will be a major breakthrough for our sicklers. Yes, we have other treatment modalities like apheresis. Apheresis means extract sickled red blood cells and inject normal red blood cells. GCRC is doing it. GCRC at Lufings.
In Lubowa?
Yes, but it's at high cost. That's why you be like...
I mean, how does it happen? Of recent, we heard about bone marrow transplant. How different is bone marrow transplant to this?
Okay. You see, red blood cells, generally all blood cells are manufactured in the red bone marrow. It means that everything begins in the red bone
marrow.
If it manufactures bad things, you'll get bad things in circulation. It means that if you transplant it and you put there a bone marrow which is okay, it will manufacture good what? That is the curable solution for sickle cell. But in apheresis, it means that remove sickled red blood cells in circulation which are already in circulation. They're already manufactured. They're already in circulation. Extract them away. You inject in normal red blood cells.
Where do they get the normal ones from?
Definitely after blood donation, people give in. They do a lot of secretizing here and there, here and there, here and there, here and there, and such that they can get packed cells, which are pure red blood cells. So that is apheresis, but it's costly. It's very costly. A person who is in foot-to-mouth economy cannot afford. Yeah, it means that yes, ministry can lobby for further funding in itself, such that it can dispatch.
So with this particular one, does it mean that they eradicate all the sickle cells, or it only eliminates those in circulation, but in the factory they are still manufacturing?
Yes, that is apheresis. In the factory, they are still manufacturing abnormal.
So but meaning it is like dialysis, that after time you have to take it.
Yeah. But at least it limits the occurrence of crises.
Okay.
Yeah, it's a good procedure.
Okay.
Yes, done by very trained specialists. Yeah, so it is a good procedure, but too expensive. That's why we always advocate for increased funding in the ministry, and the ministry dispatches some to those facilities that conduct these procedures, or even put it to our national referral hospital, such that our people can benefit from those advanced services.
Exactly. Are there any other problems as we are about to switch to probably our last point of discussion?
Another problem you hinted about it's blood shortages. That's why we advocate for people to go and donate. Go and donate, you're saving a life. Go donate, you're saving a what?
A life.
A life. Also, this issue of stigmatization in communities, but also lack of collect information in communities. So let's all, whoever has a space, increase this public awareness. We can fight and end this.
Yes, true.
We can fight and end sickle cell disease in Uganda. Yes, your family might not have a sickle, but look, your distant relative
exactly
might have this.
Exactly.
Yeah, so we can synergize and have something good.
Exactly.
Yeah.
And sometimes you might say, okay, I don't have any relative who is a sickler, but your friend, and there is nothing that hurts like losing a friend when you could have helped.
Sure.
That hurts so much. And one of the ways we can really help is by donating blood.
Sure. Let's donate. And also, you see, sickle cell does not only burden the health sector, but it burdens the economy and the GDP of the country. How will we be in a monetized economy where people are in hospitals taking care of their kids?
Yes.
How will we have a stabilized economy when people, what they're having, they're taking it to take care of sicklers? So you see, this is a very big problem.
Yes.
And it needs a multifaceted approach to combat it.
Exactly. And before we even get into what we want to talk about as we wind up, just to re-echo my voice, these days blood donation has really been made easy. That almost every day when you pass through town, at least you'll find a tent of Uganda Blood Transfusion Services or of Mengo Hospital, at least parked somewhere, calling upon people to donate blood. Please be part of this campaign. Okay, you might be so mean and say, I'll not donate to those sickle cell patients. But what about when you get an accident and you need blood? So where do you think that blood will come from? Anyway, that is a food. I'm not threatening you, but I believe when we all adopt this and donate the excess blood we have in our bodies, we can save a soul out there. Now, as we wind up this discussion, we talk about prevention and prevention, and you scared us in one of your phrases. I don't know whether someone paid attention to it. You said this is something, a lifelong disease that can not cure. How can we prevent?
Let me put a disclaimer. It's incurable, but if bone marrow transplant, if done, it's curable. So
I think the ministry is working on having a bone marrow transplant in Mulago
soon, because
Yes.
I know it's in pipeline.
It is in pipeline.
So
we pray that
yes.
it happens.
Sure. Back to what you've said, how can we prevent?
Yes.
We said if I'm a sickler, I also get a sickler. Sorry, if I'm a carrier, I also get a carrier. It means that we have a 25% of having a kid who is a sickler. So the best solution, the best preventive measure is to do premarital screening. Premarital screening.
When you talk about premarital screening, the only test people go for is HIV.
Yeah.
That is the commonest.
And actually, that's why we need to institutionalize it. We need it in institutions. Where do these couples go to get all the blessings? They go in churches.
Yes.
They go in mosques. Let our institutions, the religious institutions, help us. Put the requirement that before we bless you, we want a premarital screening test certificate.
Which has this and this and this and this.
This is very simple and very easy. It doesn't even need a ministerial statutory policy. No, very simple. Religious institutions, let them help us. Yes, at least when we do premarital screening of this disease, you go in the marriage when you know what you're going in for. You make an informed decision. That is the best solution to this. Two, how can we prevent this? Through public awareness.
Okay.
An empowered community makes informed decisions. So through giving them right information, actually they can tap and move on. Right? Yeah. So another way how we can prevent this, actually this is not prevention, but how can we have a normal health well-being for someone who is a sickler?
Managing the situation.
Yes. Well, how can we manage? We having already a sickler individual. How can we manage? Always, let's have a good diet. Let's go for immunization. Let's go for prophylactic treatments. Let's sleep under treated mosquito net. Right? Let communities not segregate. Let them not stigmatize. Let them not marginalize these families. Let's support. Let families that are having sicklers accept that we're having sicklers, such that at least they can have energies to push.
Not live in denial.
Yes. Now those are things that we can do, and also our pregnant mothers going for antenatal, because if you go for antenatal, they can tell you. But also there is another modality.
Can they detect this when a child is still in the womb?
Yes, but at early phases, we just do a screening test on the mother. But also there is newborn screening. And we're having 7 excellent centers in Uganda. The ministry applaud it, where they can do a newborn screening for this phenomenon. And they know what is happening. Yeah, such that at least they can reduce the mortality.
Yes.
Yeah.
Well, as we wind up this discussion, what are your parting shots? How do you conclude this whole discussion on sickle cell?
On sickle cell, everyone can be a victim, indirectly or directly. It requires us all to synergize, and we take this phenomenon out of Uganda. Let's not stigmatize our communities that have. Let the ministry continue to strengthen what they have initiated, and let all communities come together to fight this disease. I thank Family TV for having chosen this topic. This is through how we can combat this. Let's increase the premarital screening. Yeah.
Thank you so much. And as Church of Uganda Family TV, we are grateful that at least we play a role in creating the awareness that is really needed when it comes to sickle cell awareness. And probably as we increase this awareness, we are at least causing a difference out there, and we are building the nation. Thank you so much to you, our viewer. This has been Family Hour, Tuesday edition. Family Hour continues tomorrow, Wednesday. Now we have a lot in stock for you tomorrow as we discuss finances, and of course throughout the entire week we have Thursday, where we talk about leadership and governance. Just know that team is already ready to give you the best this year. And of course, we wind up with Family Hour on Friday as we talk about parenting. Now, we have an interesting discussion this week on Friday that you do not have to miss as a parent, as a caregiver, as an upcoming parent, but also as a Ugandan. So it is really Family Hour, fully packed. This is 2024 to give you the very best in family-friendly programs. Edwin Austin Mukalazi is my name. We had Ssekawu Barnabas, who is a sickle cell activist and a clinical officer. But of course, from the entire team, Brinko Ategeka on camera, Didmas in transmission, Jonan and Anaya producing this show, and of course a very big team putting things together to see that you have the very best out there where you're watching us from. This show will also be on YouTube, that is COU Family TV YouTube channel, playlist Family Hour. Now tomorrow is a Wednesday. Wake up with us on Good Morning Family. God bless you, and from the entire team, it's a good night.